Good afternoon.
Okay, Hamrama, 54 people have already joined, so I think we should start the class now. Okay. So the topic of today's class is preterm and low birth weight babies. Okay, it's not a very big class. So what is preterm babies? So basically, preterm babies are, as most of you have known, preterm babies are babies born before 37 completed week of gestation. Okay, so any babies born before 37 completed week of gestation is considered as preterm babies. So you can have extremely preterm babies or late preterm babies. Okay, now what are the different causes of preterm deliveries? So you can have maternal cause, you can have placental cause, and you can have fetal cause. So if the mother has any chronic maternal illness, like, yes, Baba, if you're not talking, can you please mute yourself? Okay, so the maternal causes, number one is if the mother has any maternal illness, like if the mother has congenital heart, cardiac disease, some chronic kidney disease, okay, then the mother can also have preterm deliveries. If the mother has a history of maternal smoking, if she has physical stress and exertion, these can also result in preterm deliveries, okay, and some uterine anomalies like fibroid uterus that can precipitate preterm deliveries. Now you can have some placental abnormality like placenta previa. Ecobasa, is there a problem? So you can have placenta previa, abruptio placenta. Hello? Am I audible? Is there a problem?
No, ma'am.
Okay, so if the mother has some placental problem like placenta previa, abruptio placenta, that can also lead to preterm deliveries. If there is some maternal infection like chorioamnitis, okay, or if the baby has some congenital malformation, if there is a multiple pregnancy, that can all lead to preterm deliveries. Now, what is low birth weight? So low birth weight, the normal birth weight is 2500 gram to 4000 gram. So low birth weight is less than 2500 gram. So you can have very low birth weight babies and extremely low birth weight babies. Very low birth weight babies means 1500 to 1000 gram, and extremely low birth weight babies is less than 1000 gram. So low birth weight is all the babies that are less than 2500 gram. Very low birth weight, VLBW, is 1500 to 1000. And if the baby is less than 1000 gram, they are known as extremely low birth weight or ELBW. Okay. Now there are two kinds of low birth weight babies. You can have small for gestational age low birth weight baby or preterm low birth weight babies. Some babies are premature and low birth weight babies, but some babies are term, but they are low birth weight babies. Now to clarify that one more time, look at this graph. So in the x-axis, you have gestational age, and in the y-axis, you have birth weights. And then you have the 90th centile and you have the 10th centile. Okay, if the birth weight is between the 90th centile and 10th centile, that is known as appropriate for gestational age. If the baby is above the 90th centile, it is large for gestational age. And if the baby is less than 10th centile, it is known as small for date. Okay, so this is according. You, Baba, you need to mute. Okay, you need. Okay, so you need to mute yourself. So can we mute everyone? Who's this? Who's this with the music in the background? Okay, is everyone muted now? Okay. So what happens is there is 90th centile and 10th centile. So 90th centile is when it is appropriate for gestational age. 10th centile up to 90th to 10th centile, if the weight falls between the two, then it is appropriate for gestational age. If it is less than 10th centile, it is small for gestational age, and if it is more than 90th centile, it is large for gestational age. Now this differs according to the gestational age of the baby. For example, see, if you are a 37 weeker and if your weight is 2400 gram, so for 2400 gram and for 37 weeker, it falls under 90th centile and 10th centile. So this is normal for gestational age at 37 week. But if the same baby is 33 weeker, if it is, let's say it is 33 weeker, and if the birth weight just falls right above the 90th centile, so it is large for gestational age for that baby. So for a 33 weeker, 2400 is slightly above the 90th centile. Similarly, 1600 gram bhanepachi for a 37 weeker, 1600 gram for the 37 weeker is below the 10th centile. Okay, so this is low birth weight. For 1600 gram for a 33 weeker is in between the 90th centile and 10th centile. So this is normal for the gestational age. Okay, so this is how we calculate the gestational age. Appropriate, small for large for gestational. Accurate calculation is by the graph. Okay, by this graph. Now, why is low birth weight so significant? Low birth weight is significant because 70% of the neonatal death and 50% of the infant death occurs in the low birth weight babies, because they are more prone to develop recurrent infection, malnutrition, and neurodevelopmental delays. So now IUGR and SGA babies are again divided into symmetric IUGR or asymmetric IUGR. Symmetric IUGR, asymmetric IUGR thaponogolai, you should revise your embryology first. According to embryology, you know that the baby's growth is divided into 3 trimesters. First 3 trimesters, what happens? Organogenesis occurs. Organogenesis means all the organs will be developed in the first trimester of the first 12 weeks of the gestation. Orchidita trimester, what happens is those 2 trimesters are basically your subcutaneous tissue will deposit, and subcutaneous tissue deposit also your weight gain. All these occur in the next 2 trimesters. So if the growth restriction occurs in the first trimester of pregnancy, what happens? Your organogenesis is also affected. So your head circumference, body weight, length are equally reduced. Okay. And the cause of first trimester growth restriction is usually genetic or chromosomal abnormalities, torch infection. And in case of asymmetric IUGR, what happens? Growth restriction occurs in these 2 trimesters. And what happens is head circumference is spared. So what are the causes of later trimester growth restriction? They are usually placental insufficiencies like abruptio placenta, placenta previa, maternal medical disease, pregnancy-induced hypertension, that can cause later trimester growth restriction. Now, the difference between symmetric IUGR and asymmetric IUGR, why we need to know whether the baby is symmetric or asymmetric is, symmetric IUGR, the problem is there is a neurocognitive delay as well, because brain growth is also restricted. Asymmetric IUGR, what happens? Only the weight is affected. Rest of the organs are okay. So by 2 years, they will usually catch up with their peers. Now, there are problems that are associated with preterm babies and low birth weight babies. Okay, so these they will be discussing one by one. Preterm babies go very important. These 3 problems are very important in preterm babies as well as small for gestational age. Now, preterm babies, because they cannot maintain the temperature by themselves, they can develop hypothermia. And they can also develop hypoglycemia because they cannot maintain their glucose homeostasis. And they can develop infection very early. And these 3 occur as a triad. Okay, if the baby has hypothermia, he or she can also have hypoglycemia and infection. So these 3 points are very important. If one is there, you have to search for other 2 because these usually they occur in a triad. Respiratory ma ke huna sakcha? They can develop hyaline membrane disease. We've discussed this earlier. CNS ma they can develop intraventricular hemorrhage. GI ma they can develop feeding difficulty or necrotizing enterocolitis. Because they have immature respiratory center in the brain, they can develop apnea of prematurity. They can develop patent ductus arteriosus. They can have anemia, hyperbilirubinemia leading to jaundice, and they can also develop retinopathy of prematurity. So these are some of the complications that can occur in preterm babies. Now, if the baby is low birth weight baby but term baby, what happens? Like in case of preterm, hypothermia, hypoglycemia, and infection can occur in any babies that are low birth weight, whether they are preterm low birth weight or they are term low birth weight. So hypothermia, hypoglycemia, and infection can occur in any low birth weight babies. Now, other problems in the term low birth weight. Yes, Babu. In other problems with the term low birth weight babies, what happens? They can develop birth asphyxia, meconium aspiration syndrome, polycythemia, and poor weight gain later in life. So these are some complications of term low birth weight babies. Now, how do we manage low birth weight babies, or what are the issues that can occur in the care of a low birth weight babies? Okay, so we'll go one by one. Number one is resuscitation. If you are anticipating a preterm delivery, you have to be prepared for resuscitation. Okay, a pediatrician or sometimes very low birth weight baby, 28 weeks vanda kamko low birth weight baby develop huna lageko cha bhane, what happens is you need 2 pediatricians to take care of the preterm baby at the delivery room. Okay, so you need to prepare for a high risk delivery, and you need to prepare all the resuscitation material according to the expected birth weight of the baby. So this part is also very, very important. Number 2, temperature control. Preterm babies are very, very prone to develop hypothermia. And once the baby develops hypothermia, the baby will just spiral down. They will develop hypoglycemia, they will develop infection, they can develop apnea. So if you do not manage temperature very early on in life, the baby will deteriorate very early. So why do they have so much problem in the temperature control? Number 1, their surface area is very high compared to their body weight. So their body weight and surface area ratio is very, very high. Number 2, they have a very low subcutaneous fat. Subcutaneous fat kaile aउँछ? Last trimester of pregnancy ma aउँछ. So subcutaneous fat or brown fat ko deposit is very, very low in case of preterm baby. So they are very prone to develop hypothermia. And how do we prevent hypothermia in babies? We make sure we maintain a warm chain and we opt for kangaroo mother care. So let's look at this. Let's look at this picture. This is the method how a baby loses temperature. See, so if a baby is kept on a cold surface, they lose the heat by conduction. If the baby is kept in a very drafty room, if the surrounding temperature is very low, they lose the heat by convection method. If the baby is wet, if the baby is delivered and immediately you do not wipe up the baby, dry the baby, then what happens? The baby will lose heat by evaporation. And sometimes surrounding surface chiso cha radiant warmer ko muni raheko chaina bhane, the baby will lose the heat by radiation. So there are different methods of losing heat in a baby: radiation, convection, evaporation, and conduction. All these methods should be looked after to prevent heat loss. This is known as maintenance of warm chain. So how do you maintain the warm chain? Number 1, the delivery room should be very, very warm. Okay, there should not be a drafty, duita windows open bar cross ventilation hunu bhayena. So we can prevent convection that way. If the delivery room is warm, if you are resuscitating the baby under the radiant warmer, you are preventing the heat loss by convection and radiation. And radiant warmer masa, if you take the delivery by a pre-warm linen ma use garra cha bhane, you lose the heat. You prevent the loss of heat by conduction. And if you quickly dry the baby immediately after delivery, you prevent the heat loss by evaporation. This is what a warm chain, maintenance of warm chain means. The next way of prevention of the prevention of heat losses, you quickly put on the cap because head is very large in case of babies in compared to the body, and maximum heat loss occurs from the head. So you immediately put a cap on a baby and wrap the baby like this to prevent heat loss. Another way of preventing heat loss is immediately starting kangaroo mother care by putting the baby on between the mother's chest. Okay. Now you see, this is the room temperature that is required for a baby. For a normal term baby, birth weight appropriate 28 to 30 degrees centigrade sama bhaye pugcha. But in a very small baby like 1 kg, 1.5 kg ko bachchalai, you need a temperature of 34 to 35 degrees centigrade. Okay, because they won't be able to maintain the temperature as low as 28 to 30 degrees centigrade. So that is why for a preterm babies, we can go for kangaroo mother care. We talked about this in earlier classes. So this is how we continue kangaroo mother care to maintain the temperature of low birth weight babies. So another baby, if the baby is sick, we can put the baby under the radiant warmer. This is the radiant warmer. Or if the baby is very, very preterm, then we may have to put the baby in an incubator where the temperature, this is the temperature, 34 degrees centigrade ko temperature maintain kar raha cha. So you have a controlled temperature inside a box. So this is an incubator. So these are the different methods of maintaining temperature. So you need to remember about warm chain, methods of heat loss in a baby, and prevention of that heat loss is prevention of these heat losses known as maintenance of warm chain. Then you quickly put on the cap, wrap the baby, start kangaroo mother care, or if the baby needs resuscitation or if the baby needs some ICU admission, put the baby under radiant warmer, or if the baby is very, very small, manage the baby in the incubator. Now, third point is infection control. Okay, we talked about three things. One is hypothermia, one is infection control, and hypoglycemia. Very important management of preterm baby. Three important management of baby preterm baby ma ke ke cha? Hypothermia, hypoglycemia, and infection control. Now, infection control is very, very important in case of preterm baby because their immunity is very immature. They do not have cell-mediated immunity, and they get immunoglobulins from their mother only during the last trimester. Preterm baby ma ke huncha, the last trimester ko immunoglobulin pani paako hundaina. Next one is they get their antibodies from breast milk. So in case of very preterm babies who are not able to feed, they will not get that antibody from the breast milk as well. Okay, so they're, because of the immature immunity, because they won't be receiving much of the immunoglobulins from the mother, they have more chances of developing infection. And for a very low preterm baby, they will be admitted in an ICU. They will have IV cannulas, NG tube, umbilical catheter. Some babies may also require mechanical ventilation. So there are greater probability of interventions. So this intervention will also lead to infection. So how do you prevent this infection? Number one, hand washing, and hand washing. Okay, before you touch every baby, before you enter the NICU, before you touch the baby, after you touch the baby. Okay, so you need to practice hand washing. Another way is by decreasing the exposure to adults and other children, and also by decreasing the unnecessary intervention in the babies. These are the way to control infection. And if you find that the child has infection, you immediately start antibiotics. Now, fourth one is prevention of hypoglycemia. Preterm babies will develop hypoglycemia because they have decreased glycogen storage and decreased glucose homeostasis mechanism. So how do you do it? We manage it by appropriate feeding management. We'll talk about appropriate feeding management later in this class. Now, the babies can also develop anemia because what happens is there is accelerated destruction of fetal RBC. Our RBC ko lifespan is 120 days, and for fetal RBC, preterm babies, their fetal RBC ko lifespan is 60 days. So there's earlier destruction of fetal RBC. Preterm babies on early destruction of fetal RBC. So, and they also have a low iron store. That is why they can develop anemia. So how do you prevent that? We start iron supplementation at earlier possible. So 2 months of life, iron supplementation start course in case of preterm babies. Now, number 6 is we have to manage the hyaline membrane disease. So hyaline membrane disease occurs in the preterm babies because of surfactant deficiency. Okay. So can anyone tell me what is the management of hyaline membrane disease? Akansha Singh. Akansha, can you tell me how do you manage hyaline membrane disease?
Yes, ma'am.
Yes, how do you manage hyaline membrane disease?
First of all, we need to resuscitate the child.
Yes,
if there is
and?
any sort of breathing problem in the child, then we need to maintain the positive pressure in the positive alveolar pressure in the child through
Then what is the
tracheal
definite management of,
intubation.
and what do you give?
Surfactant
Yes, so
should be given to
surfactant
the
is
child.
the, yes. So that is how you manage the hyaline membrane disease. So we know about hyaline membrane disease. Okay, so this is predominantly disease of preterm, and this usually occurs in first few days of life, and you have to be very careful about monitoring the baby. If the baby goes in respiratory distress, we send for an X-ray, ground glass opacity ionic, we give surfactant via the endotracheal tube. Okay, so this is hyaline membrane disease. Now, 8.1 is apnea of prematurity. So what happens is these babies have very immature respiratory center. Okay, immature respiratory center in the brain. So they sometimes forget to tell the baby to respire. So what happens is the baby suddenly forgets to breathe. So this is known as apnea of prematurity. This occurs because of immature respiratory center. And this is prevented, or this is treated by giving the baby caffeine citrate intravenously, or by starting the baby on CPAP. Okay, so this is the management of apnea of prematurity, caffeine citrate and CPAP. Now, another complication in preterm babies are intraventricular hemorrhage. So what happens? Can you see the brain? So you have ventricles in the brain. So these are the CT scan lateral ventricles. Okay, so lateral ventricles. So what happens is around the lateral ventricles, they have very, very fragile vascular area. So what happens in case of any stressful condition, if the baby goes in respiratory distress, or if the baby is kept under mechanical ventilation, or if the baby has received vigorous resuscitation, or even when there is a little bit of rough handling, excessive noise matra aako cha, testo bhane pani what happens? These fragile blood vessels can break, and then there is bleeding inside the ventricle. So this is intraventricular hemorrhage. If you have big intraventricular hemorrhage, what will happen? The baby can develop hydrocephalus. The baby can develop some neurodevelopmental delays because of that. Okay, so how do you manage this? We have to be very gentle in handling the preterm babies. Sudden movements, sudden loud noises, all these should be avoided while handling preterm babies. So minimal and gentle handling of preterm babies. Okay, this is how we prevent intraventricular hemorrhage, because once there is a hemorrhage, mild hemorrhage will also create some kind of neurodevelopmental delay. Severe hemorrhage भयो भने पनि some form of neurodevelopmental delay हुन सक्छ, later on leading to cerebral palsy as well. So next is retinopathy of prematurity. So what is retinopathy of prematurity? This does not develop immediately after birth. What happens is, as the baby starts growing, 28 weeks ko bachcha cha, त्यसपछि 32, 33 weeks हुन थालेपछि, there is a pathological proliferation of the retinal vessels. In the retina, if the baby is receiving lots of oxygen, there will be proliferation, vascular proliferation. Lot of blood vessels will start to grow inside the retina, and this will ultimately lead to visual loss. Okay, so how do you prevent this? We make sure that we do not use excess oxygen. Oxygen nachaine bittikai, we immediately stop the oxygen. If the baby is in mechanical ventilation, we mix the oxygen with air so that they get less FiO2. FiO2 कम गर्दै जाने, so सकेसम्म 21%. Room air को oxygen is 21%. We try to bring the use of oxygen down to 21% by decreasing the FiO2. So there should be a judicious use of oxygen. Oxygen is also a drug, so unnecessary use of oxygen should always be avoided in preterm babies. If the baby has already developed retinopathy of prematurity, the modality of treatment is the baby will either need laser therapy inside the eye, or injection, intraocular injection of anti-vasculo-endothelial growth factor therapy. Okay, so ROP develop गरिसकेपछि the baby will either need laser therapy or intraocular injection of anti-VEGF. VEGF is vascular endothelial growth factor inhibitor therapy, anti-VEGF therapy. So and all the preterm baby must go under ROP screening. So once the baby reaches the age, total gestation age 33, 34, we send them to ophthalmologist to get a ROP screening. Okay, if you do not send a preterm baby for ROP screening, what happens? That becomes a very big blunder. Sometimes this baby will come back blind. Okay, if you can start laser therapy and anti-VEGF early on, this can be prevented. So all preterm babies must go for ROP screening. Now 10 is, these baby can also develop sensory neural hearing loss, because these are causes. Maybe the baby may be very premature, so hearing loss premature. Usually your cochlear nerves are usually damaged when the baby is very premature. Okay, and then there may be use of drugs like amikacin. Okay, gentamicin, amikacin, they are ototoxic drugs. And intrauterine infection or nosocomial infection, delivery bhaisikeपछि infection bhayo भने पनि that can cause sensory neural hearing loss. Okay, these can be prevented by early hearing assessments. So early hearing assessments when detect garera, then we can go for the treatment. So for a preterm baby, once the baby is stable enough, they should go for a screening for ROP, and they should also go for a screening for sensory neural hearing loss. Now, another cause is necrotizing enterocolitis. Another complication that can occur in preterm baby is necrotizing enterocolitis. Necrotizing enterocolitis, as name suggests, it is a ischemic inflammation of gut. Okay, so there is a necrotizing colitis, enterocolitis. So this may be because of gut immaturity, birth asphyxia, and sepsis. So what happens when there is gut immaturity, asphyxia, and sepsis? The GI tract or intestine will receive less amount of blood. So there will be ischemia. Ischemia bhaisikeपछि, the ischemic part will slough off, and the baby will present with feed intolerance and abdominal distension. Okay, so usually what happens? This necrotizing enterocolitis occur in 3 stages: stage 1, stage 2, and stage 3. Stage 1 ma ke huncha? The baby, preterm baby, will have suddenly feed khairako cha, suddenly the baby will not be able to take feed, vomiting huna thalcha. The baby will develop abdominal distension. The baby can develop bradycardia, lethargy, features of sepsis huna sakcha. And if you send for stool occult blood, it can come positive. And in X-ray, they can show intestinal distension like this. Okay, in a stage 1 necrotizing enterocolitis, now what will happen? There will be feed intolerance, vomiting after each feed, abdominal distension, tachypnea or apnea, features of sepsis. If you send for stool for occult blood test, it can come positive, and X-ray will show distension of the abdomen. And in stage 2, what will happen? If this progress, stage 1 progress, the baby will go into stage 2 of necrotizing enterocolitis. There will be decreased bowel sound. There can be severe pain abdomen, abdominal tenderness, and there will be a pathognomic feature of stage 2 is pneumatosis intestinalis. Pneumatosis intestinalis is, if you can see over here, in between the bowel wall, you can see some here in between. Can you see this? These are the bowel wall, 2 bowel, white bowel wall ko bichma black lines. That is here in the bowel wall. So that is known as pneumatosis intestinalis. That occurs in the stage 2 of necrotizing enterocolitis. Stage 3 ma ke huncha? The bowel will be so inflamed that there will be perforation of the bowel. Bowel perforation bara, you can have pneumoperitoneum. This is the gas under diaphragm. Right side ko, left side ma gas is normal. This is fundic gas. If there is a gas under diaphragm in right side, then it is usually because of pneumoperitoneum. So stage 3 will present as hemodynamically unstable baby. The baby will be in shock. There will be features of peritonitis. There will be features of perforation and pneumoperitoneum. Okay, so stage 1, they usually present with abdominal distension, feed intolerance, temperature instability, features of sepsis, stool occult blood test will be positive. And in stage 2, the bowel sound will decrease and there will be pneumatosis intestinalis, that is air in the bowel wall. Stage 3, they will develop perforation, peritonitis, and the child may present in shock. So how do you manage necrotizing enterocolitis? We have to stop all the oral feeding and we have to put an NG tube inside the NG tube to take out all the gas and fluids that is remaining stasis in the intestine. So this is known as nasogastric decompression. We may have to start the baby on antibiotics and inotrope support like dopamine, dobutamine, or adrenaline. Sometimes if the baby develops perforation, pneumoperitoneum, we may also have to do a surgery. So what are the complications of necrotizing enterocolitis? The baby may develop intestinal stricture later in life. The baby may have shortened bowel syndrome, or baby can develop malabsorption later in life. Okay, so this is necrotizing enterocolitis. Now about feeding in the low birth weight babies. So feeding in the low birth weight baby is very important because it depends on the gestational age and weight. If you have a 28-weeker, 1 kg ko bachcha cha bhane janmine bittikai this baby cannot breastfeed or even cannot feed by his own mouth. Okay, so what happens is when newborn reflexes are, we studied about newborn reflexes in our clinical classes. Okay, so we have newborn reflex like rooting reflex, sucking reflex, and swallowing reflex. Now these are present at very early in birth, 22 weeks, 24 weeks, they are present, but they are not coordinated. So rooting, sucking, and swallowing is coordinated only after 35 weeks of gestation. They cannot coordinate the rooting, sucking, and swallowing. So when this is not coordinated, they cannot feed by themselves. So what happens? You can't immediately start breastfeeding in a preterm babies. So what do? First, we start intravenous fluid in a sick newborn, or if the baby is very premature, less than 28 weeks, we do not even start oral feeds. We start with IV fluids, okay? And if 28 to 31 weeks, what do? We start with nasogastric tube. This is NG feeding, okay? 28 to 31 weeks, NG feeding start karsu. They won't be able to take orally, so we start NG feeding. And once the baby grow a little bit, we start with spoon feeding. This is a Paladay spoon. Paladay spoon sign of normal spoon feeding start person. And 34-35 weeks once the baby is able to coordinate sucking and swallowing, then only we start with the breastfeeding. Okay. So during this time, what do we give? We give express milk. Mommy ko milk, breast milk na din so, express milk. So very preterm baby, a very sick newborn, now we start with IV fluids, no oral fluids, just parental feeds. Then 28 to 31 weeks, now we start with NG feeds. After that, we start with spoon feeding. Then only after 34 weeks, or once the baby has coordinated sucking and swallowing, then we start with breastfeeding. Okay. Now, along with breastfeeding, preterm babies will also require some nutritional supplementation. What are the nutritional supplementation? They will require vitamin B and zinc, vitamin D, calcium, and phosphorus to prevent osteopenia of prematurity. Okay. If you do not give calcium, vitamin D, they will have brittle bones and they can develop bowed legs or deformed legs later in life. We also supplement folate and iron to prevent anemia of prematurity. Okay, so these are the extra supplementation that you need to give along with the breast milk. So another problem faced by the preterm babies are prolonged hospital stay. So these baby will stay in a hospital for a very, very long time. If you have a 28-weeker who is 1 kg, their minimum hospital stay will be at least 45 to 50 days. So 45 to 50 dinsamma hospital bastaheri, there are lots of problems. They will require frequent monitoring. They will require lots of intervention. If you have lots of intervention, you have more chances of developing infection. And this also leads to prolonged separation from the mother to child. Then mother and baby ko bonding pani kam huncha. Arko what happens? It is emotionally and financially very trying for the families. Okay, because Emotionally, the mother will be separated from the babies, and even when you give the baby to the mother, she won't be able to take care properly because sano baby huncha daraera she won't be able to take care. And financially also, to put a baby in an ICU for 45 to 50 days is also financially a lot of burden to the family. Okay, and parental bonding is also a key issue when it comes to managing preterm babies. That is why what happens is we advocate on Kangaroo mother care. Kangaroo mother care ma ke huncha? It helps in parental bonding as well. Okay, so prolonged hospital stay is also one of the problems faced by preterm babies. Can you rejoin?